Hello, welcome to all the delegates. Today my presentation is about the prevention of the CVD in women. At this juncture, I wanted to give a brief introduction about the inequality of the treatment management and the presentation of a CVD in the woman, because this is the exact correct forum where the women gynecologist has to take care of cardiovascular diseases. As you already know, the cardiogynec branch becoming a much more than important, and the gynecologist has to pay attention whoever the woman or the lady comes to them with the gynecological problems to tell about the CVD risk and requires an evaluation. Second component, I want to concentrate on the risk factors specific to the woman so that we can concentrate on the what type of the preventions we can advise to them. And finally, I will tell about the latest guidelines of this year of ESI for the cardiovascular disease prevention in the clinical practice. Coming to the CVD is the leading cause of the woman death, and the diagnosis of the acute coronary syndrome is often challenging in the woman. A woman are less likely to receive a preventive treatment or guidance, such as a lipid-lowering therapy, aspirin, or a therapeutic lifestyle changes than in the men who has the similar cardiovascular disease severity. When the medications are prescribed, treatment is less likely to be aggressive or to achieve optimal effects. For example, when a hypertensive female is given the blood pressure goals never reached, and hyperlipidemic women, especially with the coexisting diabetes, they don't take an effective dose of the statins to decrease to the therapeutic levels of the LDL. So also cardiac rehabilitation. Nearly the 55% less likely to participate in cardiac rehabilitation programs by the women when compared to that of the men. The important old study, that is a women's ischemia syndrome evaluation WISE study, has demonstrated that not only the obstructive coronary artery disease, there is some specific features of a coronary artery disease in a female. That is, they will have normal coronaries, but abnormal coronary reactivity, macrovascular dysfunction, plaque erosion, distal embolization are the major specific female specific IHD pathophysiologies. And women with an IHD have a persistent suboptimal treatment patterns, higher mortality, and poorer CVD outcomes compared to that of the men. The sex difference may be mainly because of sex hormones, which may cause a unique gene expression and a function. The results in the variation in the prevalence and presentation of cardiovascular conditions, including those associated with autonomic regulation, hypertension, diabetes, vascular, and the cardiac remodeling, are the different in the females when compared to the men. Coming to the traditional risk factors, which are the common for the both male and females, are the diabetes, smoking, obesity, overweight, physical inactivity, hypertension, dyslipidemia. Subsequently, I will tell what is the difference between the men and women in these traditional risk factors are also, which are emerging and non-traditional specific to the females. The risk factors are preterm delivery, hypertensive disorders of pregnancy, gestational diabetes, autoimmune disorders, breast cancer treatment, and depression. Even in the diabetes, even though it is a strong risk factors for the both men and women have threefold increased risk of the CAD development and a higher mortality with an MI and higher incidence of the heart failure. And diabetes is a stronger risk factor for the stroke as well as to the PVD. So the recommendations are the both men and women with diabetes should have a proper management for the cardiovascular risk reduction. And hypertension is much more prevalent in the females than in the men after the age of 60, and simultaneously the less well controlled. So we have to encourage the optimal BP goal to reach, that is 140 by 90, with an exercise and the drug therapy in the woman. And the dyslipidemia, which is much more prevalent, about 46% more than in the men. So effective secondary CVD prevention by the statin therapy has to be insisted on them. But one of the good feature is atheroma regression, and LDL lowering is much more effective in the women with the statin therapy than in the men. So that has to be used by then all the general physicians also to have a good effect on the control of the dyslipidemia. Obesity is also incidence is more in the women, nearly 64%. That's why the degree of the exercise is advised is more than the men. That is nearly minimum of 60 to 90 minutes of the exercise is required more, and almost every day. Usually, most of the times it is told as a 5 days a week. But for a woman, because of this, especially obese, is indicated to do every day. Physical inactivity is also higher in the women, so they advise at least minimum of 75 minutes per week of the minimum exercise to come out of this physical activity. Of course, smoking, this is not proved effective in a 30 to 40-year-old females, but above the 45 years, the even passive smoking prevention is decreases the CVD risk. Coming to the non-traditional risk factors, and which are specific to the females, the first one is the pregnancy-related disorders. That is, the preterm delivery is associated with the 5 to 12.7% of the deliveries can happen during the preterm, and the ASD risk is nearly 3 times when compared to that of the normal term delivery. Hypertensive disorders of pregnancy is not only during the pregnancy, it is a risk factor for the mother survival, but for the subsequent IHD, even after the 12 years, there is increased risk. There is 16-fold relative risk for the IHD at 12 years, and 81-fold risk for stroke after 10 years, and 79-fold relative risk for venous thromboembolism for the next 5 years. Of course, gestational diabetes, even though it is a transient one, but it is associated with the 2 to 4-fold incidence of the MI in the females. The another major problem after the pregnancy is the persistence of the weight gain, and nearly a 20% of increase in the weight gain then occurs. And after the delivery, because of the increased workload, they have the less time to the exercise. To cause this weight reduction is also becomes very difficult for these females. Weight at the 1 year postpartum is a stronger predictor of the likelihood of overweight for the next 15 years, which is a strong traditional risk factor. Autoimmune disorders are the much more frequent in the females, especially rheumatoid arthritis and the systemic lupus erythematosus. These are causes about 2 to 4-fold higher than MI and 50% higher risk for the stroke. Not only the disease itself, if the treatment of the disease with an immunosuppressive drugs are also predisposed to this condition. Another important therapy is the radiation and the breast cancer. This increase in the proportion mean dose of the heart of the radiation causes the continuing risk to the cardiovascular risk for the next 20 years. So the rate of the CVD events increased by 7.4% per 1 gray of the mean radiation dose delivered. Uh, the survival of the breast cancer is enormously increased. That is very, very good. But it is at the cost of increased acute, subacute, and the late cardiotoxicity due to the chemotherapy. So the chemotherapy complications are classified as a type 1 if the anthracycline like in agents producing cardiotoxicity, or a type 2 is the trastuzumab like in agents producing it. So these people, next 5 to 10 years, it is recommended in the high risk patients to have a functional non-invasive stress testing for the occurrence of the cardiovascular diseases. Depression is also is an important the risk factors of the females, and the very few people will have an younger age group. But then as the age increases, especially by the age of the 50 years, nearly the 40% will they suffer. Previously, premenopausal state was considered as a protective mechanism, but subsequently it was then felt that because of increased diabetes, that the protective effect is gone. And but after the menopause, there is an increased incidence, mainly because of these ovarian steroid hormones, especially estrogens, which protective effect is gone. They becomes more predisposed for the CVD. So the but the trials, the WHI and HERS trials had definitely demonstrated that the estrogen supplementation is not going to decrease the incidence of the coronary artery disease in the postmenopausal condition. The major thing we have to concentrate on the prevention of the CVD, mainly the goals we have to keep, what we have to prevent it. So apparently healthy person's 10-year cardiovascular risk has to be calculated. If already has an atherosclerotic coronary artery disease, then we have to calculate the residual coronary vascular disease risk into the specific conditions like the CKD, familial hypercholesterolemia, obesity, diabetics. So first we have to risk stratify them, and then depending upon that, we have to tell to them personalized treatment. Because we say that lifestyle modification is required, psychological factors like psychosocial factors has to be controlled, risk factors to be then treated like a smoking cessation, lipid strain has to be controlled, blood pressure has to be controlled, diabetes has to be under control, antithrombotic therapy is decreased, disease specific interventions required. If you say the list of the things to a patient, it may not be implement anything to them. If you do the personalized decisions for them, like if they have the rheumatoid arthritis, for the physical activity, you have to suggest the modifications. So also the psychosocial factors. If it is in a workplace, the abnormalities, then we have to then advise and take a psychiatrist advice to do that. And so also the smoking cessation. The people who are working in this in factories, to smoking cessation becomes a difficult, and how they can change the jobs. So personalized treatment, the decisions, if you're given, that way is going to be the much more helpful to them. So once you categorize them into the different categories with the disease, without disease, with type 2 diabetes, or with the familial hypercholesterolemia or a dyslipidemic syndromes, then in the two steps we have to the control. Directly going for the higher control may be the difficult for them. In the first step, the goals has to be then achieved, like as I already mentioned, the weight reduction, the blood pressure control, the diabetes control, and the lipid control should be there. 70 LDL control should be there, 70 milligram per deciliter, which has to be increased in the step 2 to the 55 milligram per deciliter. So calculation of the CVD risk at 1 year is not sufficient. Every 1 year we have to reassess whether the cardiovascular risk is going to be changed or not. Then ultimate preventive goals has to be decided on that. According to the 2016 ESC prevention goals, the SCORE and the SCORE 2, that is modified one, and SCORE 2 OP algorithms are mainly used to classify these risk. Thus, risk is classified as less than the 2.5% of them having a chance of developing a CVD, or 2.5 to 7.5, or more than 7.5. So it is who is less than the 50 years with an estimated risk is less than the 2.5. There is no additional prevent and risk considered risk modifications, and but no additional preventive goals are required. But the same thing is not applicable when the risk is more than 7.5. Then we have to insist on the blood pressure, the levels of less than 140, if possible, is less than 130. And even the drug therapies also has to be the 100 milligrams of the LDL controlling statin group will be sufficient. But as the age increases, as the severity of the risk of the developing increases from the 7.5 to the 15, that additional drug therapies are also is indicated, like in this case dual antiplatelet drugs and DPIs, and novel upcoming interventions like EPA, colchicine are also has to be considered in them. So the intensification of the treatment is mainly depending upon the reassessment of the residual cardiovascular risk for the 10 years, and the lifetime CVD risk and the treatment benefits, and the comorbidities, fragility, and the patient preferences. So the major thing when the stop smoking and the lifestyle recommendations are the class 1 for all the group of the patients, and the HbA1c has to be the less than the 7% in the diabetic in patients. And if there is no the associated cardiovascular disease, then the a moderate restriction of the preventive measures will be the do it. But if there is a high risk of the development, then a much more appropriate control of the systolic blood pressure and as well as an LDL is required for them. And nowadays SGLT2 inhibitors and GLP-1 drugs are the much more indicated even for the prevention of the disease, even in the non-diabetic conditions. Of course, as I already mentioned, there are the few of the traditional upcoming therapies are the required when the risk factors are then very high. So coming to the patients, especially with the associated with the CKD, then much more control of the cholesterol, the systolic blood pressure is required. So also cases within familial hypertriglyceridemias, and in the diabetes, the stop smoking and the lifestyle optimization, and the HbA1c levels has to be the less than 7. So if we go for the primary prevention guidelines, early screening and the complete CVD risk assessment are associated with a reduced CVD risk in the woman. So this is an ideal time when the patient comes with the gynecological problems, it doesn't have the risk factors. This is an ideal time to tell about the primary prevention. And especially nurse health author studies highlighted this, and which decrease the mortality in the females. And what are the parameters that reduce the risk of the coronary events according to the studies? Not smoking, and maintain the healthy body weight, and consumption of the healthy diet, and participating in the moderate and the rigorous exercises, and consumption of the alcohol has to be restricted. The intra-heart study has mainly told about the nine measure the risk factors like smoking, lipids, hypertension, diabetes, obesity, diet, physical activity, alcohol consumption, and psychological factors. This study is very important for us because this is done in an Asian population. What is meant by the really the healthy diet? Adopt more of the plant and the less of an animal diet. Saturated fat should be less than 10%, and less than 5 grams of the total salt intake should be there for the day, and 30 to 45 grams of the fiber should be there, and more than 200 grams means 2 to 3 servings of the fruits per day should be there, and red meat should be the reduced, and fish is recommended 1 to 2 times a week, and 30 grams of unsalted nuts. Nuts should be unsalted per day, and consumption of corn should be restricted to the less than the 100 grams, and sweeteners and all those things are not indicated. ASA, as in the men, it is not that much protective for the female, especially for the stroke reduction is not there. So, as the ACCHA guidelines, low dose is recommended for the females when the CVD risk is more than 10%. If the low risk people, where the bleeding risk is also high, ASA is not recommended. So, coming to the drug treatment of the hypertension, as we already know, the initial therapy with an ACR, ARB, with calcium channel blockers and diuretics is now considered as the first line of the therapy. When there is no improvement, then a triple combination. That is, we can add the spironolactones, and in the third step, triple combinations can be used. But our main aim is to achieve a BP equals of less than 140/90. So the major therapy is the class one. The recommendation is the CCBs, diuretics, and RAS blockers, RAS inhibitors are the considered. Now the beta blockers are not considered as a class one indication drugs for the hypertension control. And recommendation of the treatment patients diabetes is the lifestyle changes is the class one, and a reduction in the energy intake is recommended to the patient with lower body weight and prevent a slow weight gain is a class 1 recommendation. And of course, as I already mentioned, HbA1c should be less than 7. That is class 1 indication. And the statins are nearly the 27 trials have demonstrated that the statin treatment in the female women is much more effective than in the men. So the LDL goals, that is in the step 1 less than 100, and in the step 2 less than 75 is recommended. That is a class 1 indication, and we can use the statins primarily used the statin resistant or statin sensitive. We can use the ezetimibe. Even with the ezetimibe, there is no improvement. AP6 inhibitors can be recommended. That is a class 1. And the combination of all these drug therapy when the very resistant dyslipidemia is also is a class 1 indication. Just I wanted to tell about a few of the new features which are added in these 2021 guidelines for prevention, or apparently healthy 70-year-old age without an established either diabetes or CKD or the coronary artery disease or anything, use the score 2 to risk stratify them, or score 2 to risk stratify, and mainly used to inform about the CVD risk and treatment benefits. A tailored to the needs of the patient is recommended. They insist on the personal treatment than the giving a general recommendation. And estimation of this risk factor at a one stage is not sufficient. Yearly estimation of the 10-year risk is required. And in women, the history of the premature stillbirth or who has then hypertension during the pregnancy require a periodic checkups at least for the next 10 years for the risk assessment. And in a patient with the diabetes more than 40 years of age with a high risk, then our the goal of an LDL should be the less than the 70 years. And the participation in the medically supervised, structured, comprehensive, multidisciplinary approach and preventive programs for the patients within atherosclerotic prevention, even after the revascularization or patients with heart failure, is recommended to improve the patient outcomes, especially the females in the heart failures is much more frequent. So the structured programs for the preventive rehabilitation programs has to be then attended. And the patients with the more to say moderate to severe depression should be considered for the antidepressant treatments. And we have to consider the drug interactions along with that whenever we recommend these recommendations. So I advise all of the females to work hard and decrease the physical inactivity and do the exercise every day, not once in a, not a 5 days a week. And treatment goals or the BP should be the less than the 140 if possible, the less than the 130, and the cholesterol LDL especially less than 100 if possible, the less than 70. And annual assessment of the risk is much more important, especially the people who has a bad obstetric history. Thank you all.